अस्ट्रेलियाबाट दिल्लीजी
दिल्ली बन्जाडे अनि साउथ अफ्रिकामा के भन्छ तुलसी कणेल र अर्को हाम्रो गेवालीजी अझै हुनुहुन्छ कि हुनुहुन्न हजुरलाई
हामी हुनुहुन्छ कुन चाहिँ गेवाली गोपाल गेवाली हामीसँगै काम गर्छौँ
गोपाल गेवाली मेरो हामी भन्दा एक दुई अलि सिनियर हो तुलसी दाई गोपाल दाई मेरो दाइहरु
हुन् तुलसी कणेल चाहिँ रिटायर्ड हुनुभयो केही वर्ष भयो फर्कनु भयो
ए गोपालजी अझै त्यही हुनुहुन्छ
रिटायर्ड हुनुभयो तर यही हुनुहुन्छ कामबाट हुनुभयो तर यतै हुनुहुन्छ
ल खुसी लाग्यो हजुरको साउथ अफ्रिकाबाट त्यति बेला दुईजना साथीहरू उहाँहरू जानुभएको थियो दाइहरू साथी त होइन उहाँहरूलाई दाइ नै हुन्थ्यो मैले सो ग्रेट तपाईँ कति भयो त्यता जानु
म 12-13 वर्ष भयो 2007 मा अनि हजुर चाहिँ अस्ट्रेलिया गए कति हुनुभयो
म अस्ट्रेलिया न्युजिल्यान्ड आएर अस्ट्रेलिया गरेर त 15 वर्ष भयो 16 हुन थाल्यो अब 2004 मा म छोडेको निकै भयो
हजुर कुन ठाउँमा बस्नु अस्ट्रेलियामा
अस्ट्रेलियाको यो ओरेन्जमा दिजु यो सिडनीबाट 250 किलोमिटर इनल्यान्डमा हो ठिकै डिस्ट्रिक्ट टाइपको सिटी छ ठिकै हस्पिटल ठिकै छ
Okay, good morning, good afternoon, good evening. All over the world as per the country's time zone. So we are going to start this virtual global doctors meeting. The topic of the meeting is global doctors leadership in the time of COVID-19 crisis and a path towards recovery and prevention from the pandemic. So I will just say the name of the doctors who are already in the Zoom meeting. They are Dr. Dilli Banjare from New South Wales, Australia. Dr. Leong Ying, nuclear physicist from United States. Dr. Kevin Moore, National Health Service, United Kingdom. Dr. Siba Podel from New Zealand. Dr. Rajesh Chandra Joshi from South Korea. Dr. Lochan Karki, Nepal Medical Association Central President from Nepal, Kathmandu. Dr. Pushporaj Bhatrai from South Africa. Dr. Sunita Parajuli from NY, US.
Hello.
Dr. Kesav Podel from New Mexico, United States.
Namaskar Sabalai, greetings.
Dr. Muhammad Rahman from NYU Medical Center, New York. Dr. Jayesh Patel, New Jersey, United States. Dr. Sachin Gurung from United Kingdom.
Namaste, everyone.
And Dr. Subhangini Rai from United Kingdom. So now I would like to introduce the chairperson of Girija Prasad Koirala Foundation, Kathmandu, Nepal, and she is the former Deputy Prime Minister of Nepal and former Foreign Minister of Nepal, Honorable Sujata Koirala, for her welcome remarks.
Thank you. And good evening to everybody.
Sorry, I wasn't getting time.
I would request you all to mute your microphone at this moment. Let the speaker only unmute the microphone.
I express my sincere thanks and appreciation to health workers, security personnel, doctors, nurses for their dedication and commitment who are protecting us from the front line. We are deeply grateful to you for all the sacrifices that you and your family are making so that you can take care of your people who are suffering from virus. You are truly the heroes of the COVID-19 pandemic. I welcome you all in this virtual debate and discussion of your leadership in combating the global outbreak of coronavirus. The people from all over the world will gain knowledge from each of your expertise and experiences in the prevention of this kind of dangerous virus. I look forward listening to you. Thank you. Thank you.
Thank you so much, Honorable Sujata Koirala, Chairperson of GPK Foundation America, Central Chairperson from Nepal, Kathmandu, and former Deputy Prime Minister of Nepal and former Foreign Minister of Nepal for your welcome remarks. I would like to start with Dr. Leong Ying to share your expertise and experience on this COVID-19 crisis. Thank you.
Thank you very much, Sana, for arranging this very important session and for inviting me. Blessing to Honorable Deputy Prime Minister Sujata Koirala, who I met here in New York. I'm thankful. I will try not to take up too much time because there's such an impressive collection of experts here, medical experts, that I'd like to hear a considerable amount. As I said, I'm actually a physicist. And what's a physicist doing on this channel? Well, in a way, the data is what's driving the approach of nations in the right direction or the wrong direction. For example, in the UK, Kevin Mo's probably aware of this, fully aware. The UK started off with a scheme which was similar to the Swedish plan, which was pretty much not a lockdown like the rest of the world approach, but based on analysis, in this case by the Imperial College, which was pretty dire analysis, they flipped the nation's policy over to a complete lockdown system. So the data and how the data is analyzed and presented is obviously having a major impact on how COVID is being tackled right now. Now, I have to be totally upfront that at the beginning, from the very beginning, when I was looking at analysis, my camp was more on this is no more severe than the common flu, okay? So before people jump down my throat saying, I'm fully aware of the data and I continue to analyze it. And to be honest with you, the data and the analysis has been going up and down, that even I've been considering, was I wrong? And then one moment, I was right. So you base it on the data from Italy, you base it on the data from Spain, or this is a disaster, whatever. And then you look at the data from Germany, the mortality rate is only 0.37%. Or Stanford research recently, a month ago, we believe their data, which I do because they do a comprehensive test, or the mortality rates down to 0.1. So that has been part of the problem, to be honest with you, is how the data is being analyzed and interpreted. It's the Swedish model, the correct model, which is pretty much treat this as a common flu and let's be, or the complete, draconian approach, that China approach, which is basically lock everyone into a room and basically nail the door shut. I think both extremes is not the healthiest. So what is the best mode? Well, to be honest with you, I'd love to hear that from all of you, but I already told you what my personal opinion is. And to be honest with you, I believe the current data, yes, over 300 have died, blah, 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 et cetera, but when you consider it, 1.3 million dies on the road each year, TB killed 1.5 million every year, 800,000 die of suicide. So is this cure that we are preventing, the 300,000, is that going to increase the number of suicides that's going to come? Are we going to get 1-2 million that's going to die because everyone's out of job, no work, blah, blah, blah? So is the treatment worse than the cure? So obviously, as a physicist, a mathematician, I will analyze the result. And in the cold light of day, I am due to give a major presentation in China in November. Maybe by then, I will have enough data to make the concrete conclusion myself. So I don't claim I have, because I can only feed from the data that's given me. And right now, the data, depending on who you take it from, is all over the place, to be quite honest. Now, on the other side, on the more practical side, I am working with other organizations to supply the best test kit, because I'm sure all of you will agree with me. The only way we're going to tackle this disease is really not, is it a lockdown? Is it not lockdown? It's by testing. If we don't test, we are not going to be able to know the reality of the disease. So I am working with a major international organization to supply sample test kit to Africa. Right now, Africa, thank God, is one of the least hit continents, but that could be climatic, could be various reasons, but they are preparing it. So I'm working with such organization to have them prepare the rapid auto antibody test kit for them to test at their border, etc. Again, you guys are the expert on that, so I'm not going to go into the details of various tests that's available out there at this time. So my job is to analyze the data and give the co-calculating result. Yes, it's like a horse is already bolted and we're closing the stable door. But we believe that the pandemic can come back later this year, next year, and maybe for the 3 years. Maybe the data that physicists like me can analyze can give the government and we, the people, the right policy to advocate at the end of this year, at next year, or the 3rd year. So I will do that, and I will work with my other organization to ensure that we supply the necessary equipment, the necessary medical equipment for the poor of this world, so they are not left behind. This is a real serious. It's not whether the rich can afford it. It's whether the nations of Africa, Asia, etc. That we do not leave the poor behind, saying that, oh, only the rich can, be saved here. No, that's not the way we should go about this. So that's what I have to say. I thank you all of the doctors that have been on the front line tackling this disease. Your courage is commendable. I have no courage. I'm sitting in front of my computer at home, comfortably analyzing data, so I can be safe while you guys are all on the front line. So God bless you all. Be safe, and let's get over this together and help humanity survive this pandemic. Thank you very much. God bless.
Thank you, Dr. Leong Ying, for your valuable information and sharing your experiences, that we can gain some knowledge. And we still want your updates to everyone in our emails. Please send us our email blast so that everyone can get more knowledge from you. Thank you again. Now, next, I would like to introduce or call upon Dr. Sujata Parajuli. And she is also an infectious disease expertise. So please welcome Dr. Sujata Parajuli.
Thank you so much for having me in this robust discussion. I wanted to know what aspects are we like? Do we just want to talk about like what experience we had in New York, or because so my experience in New York has been I'm an infectious disease specialist, and
right.
I from that standpoint I can share my experience about what happened here, because New York City is still what I would call the epicenter of the pandemic, and it was for a long time, and I think so when it started in China, just like overall understanding or the picture of what happened, I think when it started in China, we all felt like it might come here, it might at some point it will come, especially as an expert, we felt like, okay, it's probably going to come here. But the way I think it hit us was very hard and unexpected. But again, and obviously we were not fully prepared, because the peak of the curve of the epidemic that hit New York was so rapid that it was basically in mid-March, April, what we were dealing with was like a disaster management. We were just trying to deal with cases and serious cases. We didn't have enough test kits available. We did not have enough PPE, everything, and it was a big chaos. And I think that's, again, because of a very unpredictable nature of this virus, because it's so novel, and we all do not know, even though I'm an infectious disease doctor, like this virus presents in such different fashions, and from being asymptomatic and carrying it and spreading to everyone, and then being so deadly and killing, killing vulnerable populations so easily, it is still very enigmatic. And when it started, when it began, we all were still trying to figure out how to, even like test people, which people to who to test, and right now the situation in New York is definitely better, but as a healthcare expert, again, I think it's because of what we all did because of the lockdown, because of the social distancing, because the characteristics of this virus is that it can spread so fast and affect so many people at the same time, and being asymptomatic or pre-symptomatic can also transmit to other people. Young people can carry it. That the the extent of it was sorry, I lost the flow of what I was trying to say, but it's still very tricky because of the nature of the virus, and we are still learning a lot. It's better now. We have more tests available. We are able to test a lot of healthcare workers, a lot of people, even asymptomatic people, because the peak of the pandemic has, it's now from the tip, it has been coming down. And again, I think the social distancing, the lockdown, it's very important. The phase-wise opening is very important. Because we just don't know. It's possible that there will be a second wave. It's possible that when things are going to start very fast, or people start thinking, oh, like now it's the time to reopen, and don't care about social distancing. The virus did not change its nature. So and we do not have herd immunity, or we do not have vaccine, or we do not have effective treatment still, and the research process will still continue to go on until a long time. So if we're saying 12 months to even longer for a vaccine or herd immunity, then the virus is still there. So what should we be doing is, again, the social distancing, practicing a different new reality, and keep seeing what's out there in the literature and everything. Is there any specific question you'd like to?
Yeah, so when the audiences or when the viewers will ask the question, then we will select 4 or 5 questions to whom they address. I mean, 2 doctors, they will name the doctors to ask the question. So accordingly, then we start asking the questions. First, okay. Now we just want to hear, and we all audience all over the world wants to hear your viewpoint, your experiences, and then we get the questions then in the text or in the chat room. Then I will address it accordingly. Next, I would like to invite Muhammad Rahman, Dr. Muhammad Rahman, to share and present you are directly involved in the COVID-19 patients. Please share your views and experiences. Thank you.
Good morning, everybody. As Dr. Sunita said, that we are hard hit area. Still, we are the #1 in the world. And also, Dr. Leong, he said whatever is doing in Europe, especially Britain, we are doing the same thing. We are not locked down. We are not completely open. We are in the middle. And as you know, New York is the hub of all the big, airlines that coming from Europe, and at least all over the world, people are here. 153 country people living in, especially in Queens, So everybody is traveling, and even when they blocked the airlines, estimated like 200,000 people came from Europe and China, even after they block it. So that's why we are spread so hard. So as a physician in the hospital, and also I am a internist, also geriatrician, also palliative care specialist. I also, I have a patient in the nursing home. Nursing home is the hardest hit. Also, I have a private office in Astoria and Jamaica, those who are in New York, Mr. Somnath know how busy this area is, and
Yeah.
that area is seriously affected. We have hundreds and thousands of patients, and we see. And my personal experience, I'll give only two part. One is for the long-term care there, because it is the hardest hit. Another also my private office. The two things. First of all, in our nursing home area, we had like all elderly with so much disease, hypertension, diabetes, dementia, stroke, you name it, cancer, all kind of residents. They are closely together. And we had like wildfire in 1 week. I think 300-400 people got affected. Every floor has 15-20 out of 30 resident patient. It will be half of them or more than half will have fever and shortness of breath or something. So we did drastic measures as a part of the team. Because we could not isolate because it's not possible, and they are dementia, they will not keep the mask, so it is very difficult to treat, and they are very weak. So we make sure everybody get a vital sign check every shift, like 3 times a day. Also oxygen saturation is very important. Like people who died in the COVID-19, they are the respiratory, and most of them died with the hypoxemia, like blood oxygen is so low. So that helped us a lot. And everybody we put on certain things. Everybody we gave extra fluid, whether they can drink, we gave it. Number two, they get vitamins. And everybody given with the age, we divided. Those who are younger age, we gave azithromycin. And those who are elderly, we gave them doxycycline. We could not put the hydroxychloroquine at the beginning, because what happened, the hydroxychloroquine has a side effect of the cardiac toxicity. So as a nursing home, we don't have like EKG monitoring all the time, so we postponed that part. We gave only antibiotic, vitamins, fluid. Those who can eat, we gave oral supplement. Those who could not eat, we gave them IV fluid. At that time, hospital were packed. There was no way we can even, those who are very sick, we could not even send to the hospital, because hospital said, don't send to us any patient. We are full. We have no way to accept any more patient. So long-term care or nursing home, they had all their patient to take care of the physician, so we had no other choice to take care ourselves instead of sending to the hospital. With their limited resources, we take care of them, and thank God our mortality was not that bad like other places we heard, like they had like 20%, 30% mortality. We had like out of 500 patient, we had only, we are talking about 25, 30, like 13 died in the nursing home and another 15 died in the hospital. So it is very good rate. We did only 7 or 8%. So that is my experience. I give little bit 1-2 minutes about my private practice. We did, remote treatment like Zoom. We use Skype, FaceTime, and we tell them don't come, stay home, and give them the similar treatment. Give them enough nutrition, hydration. We gave them vitamins, and those who are younger, we gave azithromycin. Those who are older, we gave doxycycline. And also we ask them to check if they have chest pain or shortness of breath, seek hospital advice. Otherwise, don't go to hospital. But unfortunately, we did not have enough PPE, especially for the people, especially Mr. Somnath knows in Jackson Heights, Jamaica, all these places. We are coming from like Bangladesh, India, Pakistan, or Nepal, Bhutan, China. They are especially also South American, all lot of Hispanic people. They live in like 3 generations in a house, like parent, grandparent, children, extended family. So that gives the catalyst of a wildfire. So it has spread so much in the community because of it was not possible to do social distancing. It's impossible. And also they didn't have enough mask or something. So these are all the factors we are experiencing. But, my suggestion is still we have to do social distancing, even it's opens up. But mask, using mask is a must. That is my personal experience. Hand washing and using mask is a must. And hopefully, if we follow the simple, or if we can give this simple message to our people in the public, that use mask when you're out, or especially in the any contact, make sure you have mask, and as clean as possible, hand washing if we can do, we can decrease the spread of this virus, because as especially said, we don't know when the vaccine will come. So we may experience this spike in the coming winter or fall. So now I want to stop. If any question come, we can join later. Thank you very much.
Thank you, Dr. Mohammad Rahman, for your valuable advices, suggestions, and sharing your experience. Now, next, I would like to go to New Zealand. Dr. Siva Podel. How did New Zealand manage to control this epidemic in a very short period of time? As a woman prime minister of New Zealand, she did the great leaders, she's a great leader all over the world, she's praiseworthy. So please share your experience combating the COVID-19 in New Zealand so rapidly, so fastly.
Of course. Hello, namaste everyone. I'm Shiva Podel. Well, since Sujata ma'am is here, I'm Shiva Koirala. So Podel by marriage. So I still go by Koirala when I'm practicing. Podel is only for the Facebook. So we've been very, very lucky here. I think great leadership and luckily everything on time. So yeah, it's great. And also I'd like to add that I feel like a fraud because I haven't had any direct experience with COVID-19 patients. I haven't seen a single patient at all. So before I start talking about what went on, I wonder how many of you are familiar with the health system in New Zealand. It's a publicly funded health system. So people don't get to go see their specialists or into the hospital directly unless it's a life-threatening. So, then they can go to the emergency, but everybody has to come to see a GP first. And then we deal with them. And if we think they need to be seen, then we send them to the outpatients. Or if it is again acute, then we send them acutely to the hospital. So then of course, like when we had the first case on 28th of February, we all panicked. What's going to happen? Are they all going to come to see their GPs and what are we going to do and all that? But yeah, and then we had a really good support from the government and, they all made guidelines and plans. And so they took over. So we didn't have to see any respiratory patient. They were all seen at these special units. They were set up really away from the hospital, away from the public areas. So people would just go in and they would be assessed and then swabbed. Yeah, that took a whole burden out of our GPs all over the country. And since the 20th of February, slowly the cases started increasing. And they introduced the 4-level lockdown. And very quickly on 21st of March, we went into lockdown 4. That means like everything was closed, all the schools, non-essential, everything was closed. So supermarkets and things, as you are aware, were left to be open. And for the GPs, patients were encouraged not to come, just to call. So for 6 weeks, we had nothing to do really. People were so scared, they wouldn't even call. Like we had so many chronic care patients, but they wouldn't call. Honestly, I just sat in my office, sometimes even watching Netflix. It was silly, no people, nothing. But yeah, we had our hospital colleagues saying how scary it was for them. Nurses were making excuses and calling in sick, and they had to really cancel all their appointments, everything, preparing for what's gonna come. Luckily for us, where I live in this town, we had in total 47 cases. So yeah, nothing dramatic, but you could feel it in the air. Everybody was so scared. Yeah, and even people, they really helped. they were like, really abiding by the rules and practicing social distancing, everybody staying in their own bubbles. So that went fantastic. So, and then, yeah, as our cases decreased, slowly we went down to level 2 and, 3 and 2. So now we are in level 2. And there are still some restrictions, like social distancing is still encouraged. We don't wear masks. That's not being really encouraged. So I tried a few times when I went out wearing a mask, and I looked silly because I was the only one wearing it. Yeah, so now we have no active cases at all, 0. There were 22 out of 1,554 positive cases. 22 died, but most of them were all elderly people in rest home who had pre-existing health issues. And just, I think 2 days ago, I watched it in the news. The last person has been discharged from the hospital. So that's fantastic. So we are in 0 for the last 1 week. And the problem for us now, for us GPs now, is that it's all coming back to us from next week. They have closed down all the testing sites. And for all these weeks, because the schools were closed and we are now autumn, so it's winter now. So this is the flu season. By this time we would be bombarded with, all the kids and everybody with sore throat, cold, flu symptoms. Which we haven't because of lockdown. Everybody has been in home. But now they are starting to come. So what are we gonna do? Every snuffles, every sore throat, what are we gonna do? Now it seems like we have to test them. So that's gonna be a bit scary. We have set up a cabin outside in the car park. So every respiratory case that comes, they will have to be outside, and we are gonna take all precautions we can, PPE, and see them, and if needed, swab them. I don't know how it is there, but not everybody tells the truth. They come in and say, oh, I need my prescriptions, I need this. Oh, by the way, I have a cough. So, by the time they have come through reception, waiting room, and into my room, and what do I do then? So those type of things, those problems are gonna be there, and we'll have to deal with them as it comes. But so far, we're doing really well. Yeah, really sorry for everybody all around the world, but yeah, really proud to say that we've done really well.
Yes, thank you, Dr. Siva Faudel. You guys are leader in the COVID-19. We have to learn a lot from you guys from New Zealand. Yeah. So thanks a lot for sharing. So if I would
like to say something. It's almost 3 a.m. here. Will it be okay if I go back to bed?
Yeah, sure. No problem. If some questions comes to you, I will definitely email it to you, and you just answer that questions. Then I'll forward to all our audiences through our Facebook page, through our social media. Thank you for your time and sharing
Thank you so much, everyone.
Information of New Zealand. I would say the queen of COVID-19 defeating. Thanks again. Have a good night.
Thank you.
Thank you. Next, I would like to introduce or acknowledge some of our GPK Foundation members and love and support to the GPK Foundation. Miss Malini Saha, she's the founder of Indian Nitya Kala Kendra in 1992. Also a social activist and women rights activist based in New York. Next, we have a coordinator, Oceania's coordinator, Mr. Ramesh Chatkuli. Then we have a GPK Foundation advisor from Europe, Shivaji Shrestha. Welcome you all. Now, we go to Dr. Kevin Moore, National Health Service from United Kingdom. Please share your views, experiences, and prevention from the pandemic.
Yeah, so it's interesting to hear about hydroxychloroquine that was mentioned. In the UK, we have set very strict standards of what we can use, what we can't use. We have public service funding, so a lot of things has to be approved. So the hydroxychloroquine is something that's not approved. I know it's crazy in the media when Donald Trump mentioned that it was amazing for him. everyone after that was asking us for it, and it's not something we could do. We go by a lot of clinical testings. We go through a lot of evidence-based practice. So if there's no evidence for medications like that, then we simply just don't use it. On Tuesday, I think it was this week, we had a new medicine that was published as effective. This is actually licensed on the NHS, so that's kind of free for a patient and things like that. So this is actually a medicine that was used for Ebola. It's called remdesivir. It's a RNA nucleotide medicine. So this has not been used yet for us, but it's something that can reduce the COVID symptoms, which is really promising because previously there was nothing, literally just kind of managing the symptoms, having people on like heavy, like loads of steroids, ventilators, nebulizers, everything, just to kind of get people breathing really. I think regarding the things about flu and other things that are kind of more prevalent and like causing more death rates and like that, I think the COVID has more kind of long-standing effects as well. So when we looked at the CT scans, the X-rays and everything, it's the fibrosis that's after COVID is a lot more damaging than flu can cause and things like that. So yeah, it's something that we're trying to tackle, but we're struggling to find anything that's new because as my colleagues have said here, like it's so new, we haven't really faced anything like this. I don't think we were prepared for anything like this as well. The rush to find PPE for different countries, buying it from different countries and things like that. It was just a mad rush. But yeah, we are getting there with PPE. People are understanding what to do now. Because when it first started, there was a lack of like guidance from everywhere, from Public Health England, which govern all our PPE usage and all the cleaning and things like that. But yeah, I think people understanding what to do, people aren't as stressed. I think stress is a major factor that can cause so many other problems. By keeping calm and things like that, we know what to do, how to escalate and things like that. I don't really have any questions to say, but it's really interesting to hear from what's happening in different countries. Because the thing is that it's bad on my part, but I don't really read about policies in different countries because everywhere's different. Whatever like the FDA approve, we have to get our own approval. We can't just use things on the basis of because the FDA has it. But yeah.
All right, thank you, Kevin Mo. If some question comes out, so I'll definitely forward it to you, and we'll listen your answer of that questions. So far we had 2 questions. So next, I would like to go to South Africa. Dr. Pushpa Raj Bhatrai.
Okay, namaste. Thank you for inviting for this Zoom meeting.
By the way, he's also the president of NRNA South Africa. Go ahead, Dr. Sir.
Yeah, as a general surgeon, I'm not, initially we thought that we're not going to be actively involved with the infectious disease, but as the pandemic grew and everybody would be involved, so no one can be spared. In Africa, when we are lagging behind so many things in the health parameters, so many HIV positive people getting treatment, TB treatment. The concern for us is while we worry about this new pandemic virus, are we not depriving many of the chronic infectious or even non-infectious diabetes and hypertensive, other non-infectious disease, they're scared to come to the hospital. They're not getting a treatment. Most of the clinics are shut down. Initially, people are, even the health workers are scared. If I isolate one case, whole hospital or part of the hospital is closed, and they have no way to go. That's the main concern for us in our part. In the beginning, though we trying to continue our surgical service, and while we spare some of our junior staff to go and help the crisis on the COVID side, invariably we'll pick up few cases in our surgical cases, either pre-op or post-op, and the tendency to close the surgical wards, and you see so many acute surgical conditions are not taken care. we think that it needs to be. It's difficult. No, yes, it's gonna. It's nobody knows the outcome. But on the other side, we can't close everything, shut down. Though we are in the 65 days of national shutdown, we can't keep on shutdowning forever. We'll probably have to prioritize our needs. Use the people who are relatively strong or less risk to the front, and try to save the vulnerables or diseased people. And I think we need to continue, and shouldn't deprive of the other most priority thing. If you look at the statistics, we may not have many deaths or infection in Africa, maybe partly because we are not testing enough, but the numbers that are dying or deprived of the problem, or they're gonna die because we prioritizing our limited resources to this new pandemic will probably kill more people immediately and in long run, and they won't probably be counted. I think that's more for the policy makers, but in our level also, I think we need to look at this. I think we've got all the experts on infectious disease and people dealing with the COVID directly. Yes, we picked up some soft and this minimal symptoms we treat. Of the major symptoms, we do give them to the physicians and intensivists. So personally, I'm not being actively involved with the treatment or management of the active COVID patient, but as a senior member in the hospital management, and we get involved and take part in the policy making and decision making for the hospitals and the region. Thank you.
Thank you, Dr. Pushparaj Bhattaraji, for your valuable information sharing with us. Thanks again. We'll get back to you once the question comes. Next, I'd like to invite Dr. Lochun Karki, President of Nepal Medical Association from Kathmandu, Nepal. Please update the situation. We have been reading the news, watching the news about the COVID infection increasing. Numbers are increasing, and I believe 6 are already died. So please update the situation and what is the next precaution. Thank you, Dr. Lochun Karki.
Thank you, Somnath Gimereji, for allowing me to speak and to be in this platform. I can see Sujata Diju and everyone. Namaskar to everyone from Nepal, and a very warm regard from Nepal. You know, as Nepal is not an exception, Nepal is also in the globe. So Nepal can't be exception of this pandemic. So we are facing the similar kind of problem what all over the world are facing. And the situation in Nepal is getting more difficult in coming days, as Somnaji just told that the cases are increasing day by day and the graph is going up. So we are expecting more cases to come. We are expecting more cases to increase in coming days as the number of Nepalese people from other part of the country, other part of the world are coming in our country, and the number will increase more, as we know by the evidences of other countries in the world that it goes to the peak, and it'll take some time to reach to the peak and to come down. So we have just started getting the graph. You know, before we didn't even have a graph. When we looked, when we started getting data and kept it inside the graph, we even didn't had a graph before because we had less number of cases. Now, putting the data into the graph, we are just getting the graph. Now it's going up. So the things are not very easy out here. And to share, I think the preparedness is not as good as we're expecting. Being a president of Nepal Medical Association, I have to criticize in a very constructive way that the things, the preparedness are not as much as we as a doctor are expecting, because you know the preparedness means everyone by now know that the main formula to fight COVID is test. If you don't do enough number of tests, you'll not identify the case. And if you don't identify the case, you'll not be able to quarantine them. you'll not be able to treat them. So the most formula for the COVID is the test. So the number of tests we are doing in our country is not as much as we are expecting. Though in the, I mean, like comparative to the past, the number of tests is increasing, and there is debate between PCR test and RDT as well. So we are focusing, we are loving government to increase the number of PCR. So the number of tests is increasing, and the result of positive cases are also increasing as well. Number one is that. So number one, still we expect government to increase the number of tests. Number two, regarding the quarantine, you know, the lot of researchers have shown quarantine can be the source of infection. If you look into the research of Pakistan very recently, there were the quarantine itself was the source of I mean, like infection. The number 200, 300 number of patients were kept in the same quarantine. They were using the very few number of toilets, bathrooms. They were using same toilets, so they were using the same floors, the same basins and things. And if one person was infected, he or she could have infected the people who were staying in the same quarantine. So we are still lobbying for the WHO standard quarantine in Nepal as well, because lot of quarantine in Nepal are not up to the mark of WHO standard. So there should be a strict guidelines and follow up. And regarding health workers, we were expecting government to motivate health workers like doctors, nurses, but like I don't think much of the things has been done to motivate us, because the motivation is number one, PP, mask. They are not as enough as we're expecting. The government has to buy a lot of PP and lot of masks for the coming days, because lot of cases are going to come in. And PP are not reusable. We use it, throw it. So for just one patient, we need a lot of PP, because a doctor, nurses, they're going to use it, or throw it again, use it. So we need a lot of PP and marks in coming days. And if the cases increase, again, we need a lot of ICU beds, we need a lot of ventilators, and a lot of things. For example, if the number of infected cases increase to 500, we need ICU beds. The health system of Nepal will be overloaded. Then the crisis comes in. So this is, I think, lockdown is just buying time. This is the time for preparedness, and government should focus in preparing the health system for coming days. Lockdown means it's just pushing the wave. The wave will definitely come in. Nobody can stop the wave. But by doing lockdown, we are just pushing the wave, and we are buying time for preparedness, to make the graph, to flatten the graph, so that the graph doesn't go so high that our health system can't get it. If the graph goes very high and we have the capacity of 500 bed, if we have 1,000 number of patient, 500 number of patient will be in the road. So we do lockdown to flatten the graph, to preparedness, for the preparedness. So I think the government has to focus on that. So as being president of medical association, we are trying to push this message to the government, by media, by a lot of things. So we are doing that. The secondary thing is, there is a big havoc now. The other thing is like the public awareness. Now if anybody gets COVID positive, people get very afraid. Not only the patient, the people around them, the neighborhood, the other people, they 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 are treated as if they have done such a big crime. People doesn't want to come near to them. So we need to make people aware that it is just kind of a, I mean, a similar kind of influenza, SARS or MERS. The infection, when like 80% of the people will come out very easily. Only 15% has to get admitted. Even 5% will get ICU. 2 or 3%, the mortality is very less. We need to make people aware about this as well. And there are a lot of stress in the family. The old people are in home, young people are at home. They are mentally stressed, and we need to do psychosocial counseling as well. So as a medical association, we are starting psychosocial counseling from this Wednesday. So we are trying to do a lot of webinars. We are trying to make a lot of videos in multilinguistic way, as a drama, as a song, in a different way, so that people listen to it, know about it. And even we are trying to conduct trainings for infection prevention control. A lot of doctors, a lot of nurses are getting infected day by day. So we need to train nurses and health worker how to use PPP, how to prevent themselves. Because if doctors and nurses start getting infected, and if the health center started getting infected, and if they started getting sealed, and when real COVID comes in, then the country will get into a difficult situation. So as a medical, in fact, this is the role of government. So I expect government to do it, but we can't just wait government to do it. So as being a professional organization, we are planning to conduct this kind of training from Wednesday for the health workers, for the public, so in a different kind of a thing. So these are the things we are trying to do. And there are a lot of things, we were expecting recently, we had this fiscal years ending, and we were expecting this. We were thinking that Nepal would take this as an opportunity for the health system, because always there is a opportunity and a challenge. We could have changed a lot of, bring a lot of change in the health system during this COVID, because health system is always neglected in Nepal. There is no good budget. There is no, people do not talk about generally about health ministry or health personal diseases, though they write in constitution, though they write in they own a lot of things. But this was an opportunity, because every people were looking into the health system. But I think government couldn't take an opportunity to uh, bring this challenge as opportunity. So let's hope in coming days, as a health worker, Nepalese doctors are doing their best with their limitations. um, so we'll be fighting in coming days as well, like other country did. So and we need to live, as WHO said, we need to live with COVID all our life. For example, COVID is not going to just be a COVID. It is going to be like a diabetes with COPD, diabetes with orthopedics problems, diabetes with some other problems. Similarly, all people are going to live with COVID all their life. So we need to prepare people to live with COVID. And like we do HIV test, HBs, AG, hepatitis B test for a respiratory and similar kind of thing. So COVID is going to be there all our life. So we need to teach our public, our people, to live with this. So we're trying to make such kind of modules and do training as well. So this much for now, Somnathji, and I'll be more than happy to take questions. And if we have anything, any kind of discussion, I'll be actively participating in this discussion. Thank you for giving this opportunity. Thank you a lot.
Thank you, Dr. Lochan Karkiju, the President of Nepal Medical Association, for your valuable information and updates on our own country, Nepal, what's going on regarding this pandemic. Thanks again, Dr. Lochan Karki. Next, we are going to New South Wales, Australia, Dr. Dilli Banjare.
Cool.
Please unmute, please. Unmute.
Yeah, I did. Yeah.
Okay, thank you.
Yeah, Jai Nepal, and thanks everybody, and thanks Somnathji for organizing this special event, which is very useful for us. And for me, I am a Dilli Banjar, and I'm working in Australia. I am from Margakhachi, Nepal. And now I will just like to thank Ramesh Chatkuli here, who actually initiated this Oceana GPK Foundation, and we are actively involved here, and we are working together. And as soon as we got this COVID situation, we try to mitigate what we can do to our community, basically new student and parents of Nepalese origins, who are very much worried about it. And we initiate some pamphleting and this kind of things, and personal contacting including Fiji and this Oceania also. New Zealand, our Govinda Dai, he was very instrumental, and his son and his in-laws, they are very good on this, and we were working hard to give information, basically. That was things initially, and it was very good. And that was the one initial things, and definitely I like to thanks our chairman, Sujata Koirala, who is here. Probably that is one thing, and Dr. Lothan Karki, what he just now talked, and we can give some message to push something to government as well. What I accept his concern here, and I think I am covering this kind of things. And this morning, I will basically focus what Oceania, this GPK Oceania done during this last time for the snaps. And then I will talk about what Australia did to fight this COVID-19. That is very important to learn a lesson, actually, what already New Zealand thinks we got it. And then how we can relate this, our experience, to Nepal. I think that is not much, but I think Dr. Lothan is there. I think that is good to share these things. So our activity-wise is actually here, as I said, this Nepalese parents and young families, they are very concerned, and we make a Nepalese, in Nepalese language, we make a pamphlet and we communicate with them, and we distribute with Rameshji work hard for this, basically. And we have, so far, many response came from there. They are very happy to learn in Nepalese language. So it was good. And this awareness program was successful, and so far we get good feedback as well. And what Australian approach to fight with COVID-19, that is very important to share, I think, because this is a successful country so far. If second wave can come, but if it doesn't come, then we are very good in shape now. Very few cases, 4 or 5 cases per day in nationwide. And the major thing, as Dr. Lawson also indicated, actually, the main thing is timely lockdown. Australian government decided on time, and timely lockdown as soon as it come up, not like USA and US, UK, they also missed, but Australia did well on time. So that was one main thing, and closing interstate border and the international border, both. So this is important for Nepal also, because national and international border are in our country as well. So, and another is test. That is just as medical people, everybody talk about. And our test is now, so far, Australia tested 143,000 tests until yesterday, and only 0.5% positive case. If you compare US, you are experiencing there you have tested probably how many, 1 crore, I think, 10 million cases, and the positive rate is 7.7%, 7% positive case, 7.7, meaning there is no test. They have to test many, because they should be getting 0.5% only, but they are getting 7.7. So it means test is not there. So test is working well. And the third is government policies based on professional advice. Australian government, always Prime Minister, side of the Prime Minister has this chief medical officer sitting there. He don't talk his voice, he talk professional voice. So that is very important, because other countries didn't do this. Most likely in Nepal also there is no such thing. Even medical association might not have concern closely. Dr. Lawson will probably expel, but I think government is not on that proactive approach for professionals' advice. So that is another thing. And another is contact tracing, using all government and private agencies, private hospital, government agencies, NGO, INGOs, schools, university, every people involved for contact tracing. There is a test and there is a contact tracing. Then it is a control. It is easy to control. That is our experience, basically. And another is effective quarantine. Quarantine, just before Dr. Lawson just noticed that quarantine may spread the disease. That is, we know. So here, what Australian government did, the government put all immigrants who are coming from overseas, they put in star hotel. Money is not important at this point of time. Even in Nepal, if you spend 10 Arab, I think that is paid back because of this saving our health, per capita health. So that is investment basically at this point of time. So this hotel are free. No, they are vacant. Why government just paid money and put people in the hotel and good quarantine? Then it is a good business also. It is a good for rolling the finance things also. So that is also one approach Australian government took into account. And government support for livelihood during shutdown, job keeping allowance, and other financial assistance for everyone. That was another milestone. And another is organize enough PPE, increase ICU beds, ventilators, and other logistics during this buying time. Now we are ready. If second wave comes, we are ready to go already. But as Lotan said, Nepal is just buying the time, but no using. This government is not using at all, what I can see. There is nothing there. So these are the main things I think we know, but we have to emphasize more to learn, to transfer to Nepal. So Nepalese context, now I'll just try to tell in Nepalese context how we can do things. The trend is, as we know, this trend is the curve is not peaking. We have less test, maybe many cases, but still we are not peak, definitely. So if we are not in peak, so what we should be doing is we have many months to go. So which way we go? We close the lockdown, or we keep continue, we relax the lockdown and use other measures. So that is a confusing situation, definitely, and the government is probably, government should accommodate every advice. And in my opinion, what I can see is, I think make a little relax, but same time release lockdown and maintain social distancing effectively, and effective quarantine, what we just discussed. So that is more important, I think, in Nepalese context. And other things, what I like to emphasize is government should work efficient quarantine measure, test. That is important, and the trace. That is another important. These two things has to go together. So, and same time, we have time now, so we have to increase patient care facilities in another sense. So these are the main important things we should be doing. And another point I like to say is, now we have to build these facilities specific for COVID treatment. That another advice in Oceania we discuss among us, like Rameshji and we, different, like Rameshji has some financial expertise. He's like a chartered accountant, so he know more. So that way we, hello?
Yes, go ahead, doctor. 2 more minutes, please. Two more minutes. There is no time. We have other doctors too.
Yeah. So that way, what we did is, if we make 7 big hospital in every state, because this is a state concept. So, and at the same time, we can address Govinda Keshi's demand. Dr. Lochan is here. I think that is good opportunity for the government, if we can tell something. 7 state, big hospital for current corona case, but from next year, we can convert them into medical college. So that is one thing. And another, lastly, I like to emphasize that our experience, what we tell is, I am working in a cancer specialist. So I'm working in the radiation oncology, basically radiotherapy, and our patients are suffering. So in Nepal, many patients are suffering, most likely, like a cancer, diabetes, cardiac, heart patient. And yesterday only I read one newspaper. There are few mortalities because of lack of this delivery attendance. These pregnant women are dying because they are unable to go to get assistance for delivery. So that kind of things, we have to keep that service intact.
and emergency service intact. So that how we can do this, government can do. I think this time government is not looking at all. So we have to push the government at this point of time. I think that is more important for policymaker basically.
Thank you.
Doctors are working fine. Every professional are good, but policy is not right in Nepal. So that we should be doing, and we have to push government as much as possible. Thank you.
Thank you very much for your valuable information and advice, Dr. Dilip Banjare from New South Wales, Australia. Now we come back to the United States. And I would like to invite Dr. Keshav Paudel, with whom I was almost infected by this COVID-19 at the beginning. From his telemedicine, teleconferencing, from his advices, I managed to defeat this COVID-19. Thank you for your valuable advice, Dr. Saab. And he is the immediate past president of NRNA America too. Please welcome Dr. Keshav Paudel.
Thank you. Namaskar, everyone. Thank you, Somnathji, for this opportunity today. And I would like to express my sincere thanks to Honorable Sujata Koirala, Chairman of GPK Foundation. And I would like to greet every one of you. And I enjoyed listening to you all. And I have to start with the COVID-19 not only threatens human life, it has threatened the livelihood, and it will threaten the culture, what we live life in coming days. And I have been talking and I have been working with this COVID since the beginning. And as Somnathji pointed out, I am a social worker and I am a physician. So I work as an internal medicine internist and hospital medicine. I take care of the COVID patients directly. And so I have to start from Dr. Leong Ying. He said, yes, so you have gave very good talk, but I have a few things on that. So you said, okay, people are dying from the accidents and suicide and flus and so many other things. And as an analyst, yes, that is true. But this disease, as we know, it's an invisible enemy. It's new. We don't know anything about this. We knew about those flus and previous disease, suicides and accidents, at least that affects those individuals who are doing those. But this disease is different because this attacks people who are not involved, who have not done anything for this. They were not doing themselves any risk. So this is very important. And this has killed almost 370,000 people throughout the globe. And 66 million people are already positive. And the burden of this disease is very high. It's not only 6 million people. For example, if you talk about New York or Italy or England, there were so many people calling, at least if I can talk about the Nepalese who called us. They were looking for the test and there were no tests available anywhere. And what I have suggested, Somnathji is one of the examples. Don't worry. If you have a fever, take Tylenol. Hydrate yourself. Eat protein-rich food. Take rest. Do some exercise at home. Don't try to call the hospital. Don't go to the hospital. Even though you go to the hospital, they will send you back home unless you have pneumonia, a respiratory problem, or you are severely sick. And I have done that for whole old people from Nepalese origin. And that was true because so many people got recovered without testing. The burden of the disease was very high and is still very high. And so because it is very important, because we don't know about this disease and the virus is invisible and we don't know when we're gonna get it. And so many healthcare workers are affected. And at least in the US, I can tell more than 300 healthcare providers have been died of this disease. It's a very severe condition, serious condition. And it's a public health emergency. It's a pandemic. And it has come in last 100 years after Spanish flu that claimed life of 50 million people. After that, this is the major pandemic we have experienced in human life. And it will continue. So we know coronavirus was there since 1968. They found then. And the coronavirus came as SARS and MERS. But those epidemics died without any problems. And the efforts to control them was not seriously taken then. But the medicine, Dr. Kevin Moles from England said, okay, yes, we have been using remdesivir, yes. And Dr. Mohammed said, we have been using chloroquine and azithromycin and all those. That was all in the beginning. Nowadays, FDA hasn't approved any of those medications and they have been taken off the market for COVID. That was when we had a lot of people dying in New York out of desperation. We said, okay, we can use hydroxychloroquine. We can use azithromycin, or we can use any of the other medications. Now the paradigm has shifted. We're not gonna use chloroquine or azithromycin or doxycycline or any other medications. And remdesivir is a direct antiviral medication that acts on the virus RNA, polymerase enzyme. And that has been approved for emergency use only. FDA hasn't approved for a long time. This is just for out of desperation. This is not final. This medication will find ineffective, and this could be taken off the market. But for now, yes, remdesivir is antiviral medication that will be used. In the beginning, as I mentioned, azithromycin or chloroquine or doxycycline or tocilizumab, that is IL inhibitor, IL-6 inhibitors. Those were the medication used, but they are not being used anymore. From my practice, I used all those medications in the beginning, but now we check procalcitonin level for people who are admitted to my floor. As someone already said, 15% of the people go to the hospital in regular floor, and 5% will go to ICU. And I see those 15% that go to the medical floor inpatient. And we check procalcitonin. If procalcitonin level is high, then only we give antibiotics. If procalcitonin level is low, even though they have pneumonia, that is viral pneumonia, that is due to COVID-19, that will get better without any treatment. Only we need to do the supportive care. But in cases, they have a high CRP level and high D-dimer level. These are the two mostly measured inflammatory markers. If they are high, then we use steroid on top of any antibiotic, but antibiotics are not the mainstay of treatment right now. So only supportive care, and if we have available, we can use remdesivir. It has a criteria. You have to have oxygen level less than 94%. And then you have inflammatory markers high and you have a virus active. Then we use remdesivir. So there are so many other centers, they are trying to find out medications, but it will take a while before we know that what medication will work. And the topics, today's global doctors leadership. Yes, all the doctors throughout the world have done phenomenal job. They have shown their leadership. They have come out to go to examine the patient without any hesitation, even though they didn't have enough PPEs in the beginning. We had all PPEs for my experience in my hospital. We had the PPEs and we didn't have a case. Everyone was saying, okay, this virus will die down in China, or even though it comes to US or other countries, due to the temperature, it will go away. And all the political leadership were thinking that way, as President Trump said that, and he announced, okay, this disease will die in April. No, that was not true. That was not based on scientific data. And CDC is the main leader in the US for this infectious disease. They were not able to show the leadership. And everyone else around the world look at US. And we were not able to show the political leadership. But clinician-wise, doctors, nurses, and all the healthcare workers showed their leadership, and it was exemplary. They have done outstanding job. And so, as I mentioned to you the experience, people were calling me all around the world, and I had received at least 15 calls a day from the people who were panicking. And I had to tell them, okay, we don't die of COVID. 80% people will be okay at home. 15% will go to hospital and 5% will go to ICU, and 1 or 2 people out of that 5% will have a problem. If they have pre-existing conditions like uncontrolled diabetes, kidney failure on dialysis, chemotherapy for cancer, and other compromised conditions, and heart disease, liver disease. And people started knowing, the awareness has been created. In Nepal, I want to talk to Dr. Karki is here. They have done a good job pressuring the government and giving pressure to the government along with the other parties in Nepal. However, the effort was not adequate. And they have done 3 months of lockdown, and they were just sleeping. Lockdown is time to buy, this is the time to buy time, and then do all those measures like they have done in New Zealand and Australia and Singapore and so many other countries. And they were able to be successful. In Nepal, we just walked around. We said, okay, Nepal, we will not have a disease. Nobody has it. And that was not true. This is a virus. This goes around. If not today, it will go tomorrow. Even in Africa, Dr. Puspa Batra is my friend. He is there. I'm very excited to see him. And they don't have a case burden right now, but it will be there sometimes. So we need to be prepared. But how can we survive in the future? Everyone is like telling us today and sharing their experience. The most important thing is testing to find out or avoid clusters. This one sporadic case will not do anything. But if one case gets into 10 and becomes cluster, and they will go into community outbreak and pandemic, epidemic or endemic, whatever it is, endemic. So Nepal, most of the cases are sporadic. Still, they don't have a clusters. Only they have found in the people who have come back to the country. this is still have a time, but we need to have a policy. The government cannot say, okay, we cannot bring our people from other countries. It's government's responsibility to bring their people. And they need to have a policy to quarantine appropriately with the standards. Dr. Karki mentioned that the quarantine process increased the disease burden. Yeah, that's true, but we are not practicing the optimal quarantine or isolation process. Quarantine means one person will be there in one room, not 10 people or 100 people. So I have been telling that since the beginning. I have heard in the, like 3 months ago, that Nepal, they were quarantining like 20 people in one room. That's not quarantine. That's risking people. If one of them has a disease, all 20 people will get the disease and some of them will die. It's better to leave them to go their home and then ask them to stay away. Don't go to the community rather than putting them in one room. So everyone needs to practice the standard precautions, standard quarantine, isolation procedures. Then Nepal, in the beginning, they did all the rapid testing. That is a antibody test. Nobody had done that. So in the US, if you ask me, they have been able to test 16 million people. And out of 16 million, 2 million have a positive test. It's a 12%. But I'm sure this 16 million is not the true data for COVID. It could be 50 million people. They have a COVID in the US, but they have not been tested, so that we don't have a data. And overall, it's not 12%, maybe you mentioned, it's maybe 0.5% or 1%. And death rate is high. The flu has a death rate around 0.4%, and this disease is at least 10 times more lethal. And now the disease, overall, from the data, it shows that 3 to 15% of the people have died. 3% if you are healthy and young, and 15% if you are elderly, more than 65 years of old, and have multiple problems, or you live in the institutional settings. So this disease is a serious disease and it kills everyone. But if we take appropriate precautions, we don't need to lock down. We can prioritize and stepwise approach to open the country all over the world, not only US. Everywhere we can open the economy, we can open the country, but we need to prioritize and have policy, avoid clusters, have a face mask and gloves and sanitization and social distancing, all those things. So we can keep talking, but there are so many things we can talk. But most important thing is all the governments all over the world have to give appropriate information to their citizens, that is awareness and education. And they have to assure their citizens that they have enough healthcare system and they can take care of them if they are sick. And for healthcare providers in every country, they have to assure that they will be able to provide appropriate PPEs and they will not endanger their life to see the COVID patients. And that will be the standard. And even if they have a problem, so now they have to bring that. I have not heard that before, but if some healthcare providers get COVID and they die, their families who are left after should be taken care by the government. That hasn't been discussed anywhere, but that is my personal opinion. And that should be the case to make sure those healthcare providers are confident to take care of the patients in case if they have appropriate PPEs and they practice good isolation, like standard precautions, they will be fine. But in some instances, it's not only that particular healthcare providers, their community, everyone needs to practice the same standard and prevent infection getting to each other. So these are the things. And then other thing I can tell that this will be a problem until either 50 to 70% of this like population of the universe will get infected by this virus and get immunity. It's not only one country. If they have immunity in China, that will not prevent disease coming to the other country. But overall, human population all over the world, it should be at least more than 50%, but they have said 70% to have herd immunity. The immunity that the infected people who have been recovered provide to the people who have not had the disease. So number one. Number two, we need to have a treatment like remdesivir we have tried now, and there should be so many other medications to come in coming days, but we don't know when. And the last thing is vaccine. If we have a vaccine, then we'll feel safe until this virus finds new mutation strain. But so these are the survival strategy we need to have, and then until then, all over the people from all over the world needs to practice good precaution measures. And again, I want to mention that this is a novel virus. We don't know everything about this, and in coming days we'll know so many other information. And this is not like accident or suicide or flu that we already know. This is different in the aspect that we don't know anything, and it's invisible enemy to human life. Thank you all. Thank you for the opportunity.
Thank you, Dr. Keshav Paudel, for your valuable information and sharing your experiences to all our doctors around the globe and to our viewers. And GPK Foundation Facebook Live is still on, it's going on. Now we have 15 more minutes to conclude this forum, and the last speaker, just make it short, and then we have few questions to ask. Dr. Sachin Gurung from United Kingdom.
Namaste, everyone. Hi, I'm a GP in south coast of England, and I've been working in the primary care setting, looking after people with COVID and without COVID. Now, due to this pandemic, I think we have to consider that everyone has COVID, or has coronavirus, unless proven otherwise. It has taken a significant toll on not just the physical health of the general population, along with the health workers, but also the mental health, social, and the economic impact to the entire globe. So I think it's really important that we have a conversation, especially amongst the healthcare workers, on a regular basis, so that we can share information and share ideas. So I'm really grateful for this opportunity that we could have a platform to do that. Now, my heart goes to the people who've been suffering, especially in Nepal, because of how poor the health care system is there at the moment. I think this pandemic has not just shown that there are cracks in the healthcare system in the developing countries, but also the first world country. And then there's a lot of important lessons that we can all learn from what we're going through. I just wanted to comment on what Dr. Karki said earlier about that you have to live with COVID for the rest of your life. I think that is quite a grim and morbid statement. I really hope that it will not be the case, because Spanish flu happened a century ago, and it did kill a lot more people than COVID has so far, and it's not there anymore. And then Spanish flu, there was no vaccine for that as well. So I don't think all hope is lost, because it's not just healthcare professionals, but also the non-medical people who are watching this conference. So that is the message that I would want to give them, that please don't be disheartened completely. I think the main PPE, the most strongest PPE that you can have is common sense. And do follow the guidelines, do maintain social distancing, and especially for the healthcare workers all around the world. What I would like to say is that, yeah, even in first world countries, PPE has been a really big issue, and then there's been a really big shortage, not just in the hospitals, but also in the community. Just in the UK, initially, there was such a big shortage of PPE, and not that, but also hand sanitizers and even hand towels, because I've actually worked in clinic where I wash my hands and there was no hand towels to kind of dry my hands with because of short supply, because like most of the equipments had to go to the hospitals, so the community settings were not the main priority. So many deaths in the community and in the nursing home has shown that we cannot ignore the community and the primary care settings. What I would also like to say, especially to our esteemed politician who we have amongst us, Sujata Koirala ji, that I think because you're a politician, and then you are a very important part of the government, that we obviously do need to listen to the healthcare professionals in Nepal and get advice from the scientists and the epidemiologists. I'm sure you all, the government is already doing that, but I think they need to be leading this pandemic to help to get over it. The other thing is that there are so many people outside Nepal who are not in the same privileged positions as we are, where we can just stay away from going back to the country, and we can stay abroad, because there are so many people, especially in the neighboring countries of Nepal, that who want to come back in, and I'm sure, and of course, they should all be let in without being tested and quarantined, but also at the same time, I think that in a cohort of people really need to be looked after as well, because they are the ones who are really economically deprived. Sorry, one last comment about what Dr. Keshav Podal said earlier about not to call the hospital. Here in the UK, if you call hospital switchboard, it will say that if you have coronavirus symptoms, do not call the hospital, do not come to the hospital, but call the NHS helpline, or the healthcare professionals. I think even if you do not turn up blindly to the hospital, please do call police, because obviously you will not, I do completely, 80% of people do not have any serious complications from this virus, but that's the fortunate 20% of the people who suffer. And then unless you are either assessed over the telephone or via video or in person, the general population is not going to know if they do need any more treatment. Yes, so I think that's where I would like to end my comment, saying that please look after yourselves and also your friends and your family. And also, I think especially right now, the world has kind of shown the limelight on the healthcare workers and how important they are. I've been listening to, I've been reading and looking at a lot of media news, especially in Nepal, where healthcare professionals have actually been assaulted by the general public, which I think is really abhorrent. And I think that actually needs to be looked at very strongly by the Nepalese government. Thank you very much.
Yeah, thank you so much, Dr. Sachin Gurung, for your valuable opinion and information. I look forward for the questions QA sessions now. We have 5 questions. First, I would like to ask Dr. Sunita Parajuli. I have a question from David Chu from Seoul, South Korea. And I will add it to that, the question, same questions by Malini Saha. Her sister was expired due to COVID-19, and it's very sad and heartfelt condolences to Malini ji, and we pray for her soul rest in peace. So this question goes to Sunita Parajuli, David Chu from Seoul, South Korea. As you mentioned, you are infectious disease expert. Do you think there will be another most dangerous virus than COVID-19 upcoming? And also, I connect to you, Malini Saha, for your question. Please, Malini Saha, go ahead, ask your question.
Yes, sorry. Yeah, unfortunately, I lost my sister due to COVID in the month of March, and I'm so happy to join this. Thank you, Somnath ji and Sujata ji. My question is, how is it truthfully transmitted? Can we, do we have to take our clothes off soon as we come home? And, you know, there's so many rumors going around. So what is the precautions apart from vitamins and rest?
I'm so sorry for your loss. Thank you for your questions. But I'm also very sorry for your loss. I know it's not easy. This virus has, you know, it has affected so many people, and losing lives. It's not easy at all. To the first question, could there be a deadlier virus than this, right? So what we know is that there are so many viruses in the world. There are so many viruses. So SARS-CoV-2 that causes the coronavirus disease, that's a novel virus, right? And that's also a zoonotic virus that comes from bats. That originally, the origin of the virus is from bats, and then it somehow mutated and came to humans, and it changed its genetics and everything, and became so fatal or infectious in humans, and it spreads. But it's only one of them. So there are apparently more than 140 million viruses, wild viruses that's there in the forest, just in nature, that could potentially mutate and ultimately transmit to human. So it's not that it is impossible. I think with coronavirus, this particular SARS-CoV-2, we kind of got an idea now, the amount of spread that happened. It's definitely, the fatality is higher than flu, which is, from 0.1 to 4.4 to 1%, most likely, even though we do not know the full data yet. But it is not as fatal as viruses like Ebola, right? So Ebola was a very, very fatal virus. And Ebola it was almost 50% fatality. So there are deadlier viruses that were already there in the world. But with Ebola, it's interesting is that if something is very fatal, what happens is a virus it needs a host to be transferred from one person, human being, to other. It requires a host to travel, to keep spreading. With coronavirus, it has a perfect timing because it has a perfect balance, because it transmits with asymptomatic people, pre-symptomatic people. So they don't even know they have it. So they are transmitting it to everyone. What happens with fatal viruses is they get killed. So you're not transmitting it to as many people as it would with coronavirus. So I'm not saying that it wouldn't transmit, but that's what we've seen. Like, for example, with Ebola or SARS or MERS, it was way fatal than coronavirus, SARS-CoV-2. but it didn't spread that badly to the world. And I think that's because of that host specific factor. But again, it is possible that there could be deadlier viruses than this. And I think that's why in our generation, this kind of opens up our mind to be like, kind of understanding, like to understand what could happen, and there could be another pandemic. It's possible that we all need to be prepared. It's not easy to prepare for a pandemic at all, but at least to whatever you could do, disaster management, stockpiling, things like that is very important. I think that's what this pandemic kind of opens up our eyes to. The next question from Ms. Malini was regarding the transmission, right? So the majority of the transmission of this virus is from droplets. Initially, we were even not sure how it transmits. We were even thinking it could be airborne, which means that it can stay in the air for a long time with tiny droplets or tiny particles, and it can spread like tuberculosis does. But as we learned more, we found out that it could stay in the air for some time, but it doesn't really, it's still not, it doesn't stay longer than 2 to 3 hours. And the most effective transmission for this is droplets. So someone speaks, someone talks, coughs, sneezes, the particles go out and then it settles. It's in your hands, it's in surfaces. So you touch doorknobs with the same hand, you didn't clean your hands, you didn't wash your hands. The other person comes and opens the door, touches the face, then it's transmitted. So it's through droplet and contact mostly. To your other question regarding transmission from clothes, right? So what the data does show that this virus actually lives in different surfaces for a long time, especially steel, cardboard, plastic, things like that. It actually stays for 2 to 3 days, which is very crazy. But with the fabric, it could. So that's why when we work, we are very careful. What we do is when we're in the peak, when I saw coronavirus cases, I basically, like whatever clothes I wore, I would just, when I come home, I would just toss them out, would not, just directly laundry, shower, and then only come to my living room. So because it's possible that it settled in your clothes for some time, and then that clothes came in contact with something else, and then somebody else comes in and then touches that, then it could transmit. But then I was wearing PPE. It is just being extra cautious that I could have acquired it. It's possible, but it's not like the biggest way of transmission. But to be extra cautious, it's good to remove your clothes that if you came in contact with, if you're in public or if you were in contact with other people, if you saw patients, it's best practice to remove those clothes and wash, clean, and then continue with your life.
Thank you so much. That was so well answered. What about flying? I guess we are not prepared. I mean, it's best not to right now. Avoid it as much.
To fly, I think flying is, it's again, everything in this, I think, new COVID reality is going to be different. I personally, I did not even travel and see my family who live in New Jersey, and my family back home in Nepal. My some of my family members are in New Jersey. I did not see them for 2 months because I was scared. I was scared that I could potentially give it to them. Now flying is entirely different. It's even more riskier because you're in a very closed compartment, and I know that travel airlines and everyone, they are also preparing more new policies that they need to wear masks. There has to be some distancing, even like there should not be three seats should not have like 3 people there. It should be only 1 person in 1 seat. So I think they are also making all these policies. I think as as a general public, we should be very aware because we at least know some of the answers to the questions like We know that it will transmit if you're very close to a person who's coughing, or could even be asymptomatic, you're talking, it could transmit. So I think if someone is not practicing those guidelines, we should avoid that.
Thank you.
Next question we have from Dr. Kevin Moore to Dr. Keshav Paudel.
Yeah, my query is kind of specific. So, so we've had people who have had pulmonary aspergillosis, which is COVID associated. Because there's lack of guidance with this sort of thing, what is kind of the duration of treatment that you have seen? What kind of biomarkers are you using, and like, are you kind of guiding durations on CT scans and kind of reports and things?
So that was a very specific question regarding aspergillosis in the setting of COVID. I have not personally seen those kind of cases, but we have a practice that any pneumonias, if they are not getting better with all those treatment, like we used to use for community acquired pneumonia, like ceftriaxone and azithromycin, if they are procalcitonin positive, then we have added steroid. But I have not heard, or I have not experienced personally about those aspergillosis cases. And treatment for those pneumonias with the antibiotic is 5 to 7 days. And steroid, we gave like a high dose steroid, like we treat for asthma, COPD, and pneumonia, 7 days, and then taper them off gradually. And they did well. So their oxygen requirements were improved after we use steroid. But I think for aspergillosis, if that is treated with the steroid, they should be fine. But I don't have personal experience on that.
Yeah, so we'd be using ambisome. I think we'd be using like
amphotericin is given. On top of that, they could use any steroid to decrease the fungal burden. Maybe that is, I don't know if they have any cases reported, but I have not heard that. So that is very special case. I'm sorry, I don't know the answer to that.
Thank you so much for both doctors for clarifying that. Next, we have a question for Leong Ying. You mentioned earlier that Swiss model of COVID-19 test kits is more effective than any other test kit. What is this economic way? How is it? Is it cheaper or is better? Well, why do you mention that? Can you please clarify?
Well, thank you for that question. So as a few of the other doctors mentioned, and correctly, we're not going to tackle the disease unless we can test it, unless we know what this disease is doing in our society. So testing is the number one. That's the reason why I worked in Australia. That's the reason why I worked in New Zealand. That's the reason why I worked in Germany. Okay, so it's testing. Okay, so obviously there's two types of tests. I'm not going to go in detail because these experts know it better. There's basically the DNA testing of the sequence of the RNA. The problem with that is that's very sophisticated. It takes a long time. It's expensive. You need a professional lab, pretty much manned by PhD technician that needs to make sure that every single sequence, every preparation is done. That may be okay here in America, in UK, in New Zealand, but that is not what you're going to get in a lot part of the world, the problem. So the other testing is the antibody. Now there's various variety, but those are the two essence. The DNA, which is obviously the most accurate one, but it's the most expensive, the longest, and you need expert, and then the antibody. So with the group that I'm working with Galaxy and Future Trends, one of the big issues I'm working with Africa, I'm not going to go into detail because that's confidential where we're working with, but a lot of the issue is the migrant at the borders. There are people flowing at the borders, and how that is done is obviously a refugee issue. The commerce, cargo, is that they need a test that they can do and get a result immediately. You can't hold someone at the border and say, wait 3 and 5 days at the border while we get the result. It's just not practical. So obviously the only viable test is the antibody test. Now, it is a new test. There's obviously part of that problem is because it's new. There's a lot of false positive, false negative. So the reality is the test a good test or bad test? Obviously, the test kit we are using, we believe is a clinically tried test. I'm not going to mention it because I don't want to be publicizing it, so I don't want to use this as like a publicity platform. Those that are interested, you can contact me. So that's the test kit that we are supplying samples right now to various African nations, so they can have a rapid positive, negative test. So as many of the views said, information data exchange is the most important. So with the test result, and again, I'm not going to say our antibody test kit is the best in the world. We have the clinical trials. FDA's approval takes years and years to approve. So like the CDC, they have allowed an emergency authorization use for these antibody tests, where they're developed in the US, where they're developed in Europe, where they're developed in China. It's all the same. These antibody tests have only been evolved in the last few weeks. So I'm not going to be here saying my test or that test is the best. We really, really don't know. That's the problem with the disease. As mentioned, this is a novel thing. We are getting the information. I mean, obviously, by the end of the year, hopefully we will have the full information regarding the test, the full information regarding the mortality, the severity of it. As Dr. Pudaf said, he's absolutely right. You know, I cannot be, you know, the God figure that sits here and says, I know everything, everything's right. I told you, I'm just sitting in front of my computer. It's not for me to play, well, you know, my data is better than your data, et cetera, et cetera. We all don't know. So that's why we all need to exchange. And that's why this platform is absolutely, absolutely must. And we should have this on a regular basis. So you have brought the whole world, Africa, Europe, Asia, US, on this. And that's exactly what we need. We need experts. And these are amazing experts that I'm hearing from, that I'm learning from, to exchange the information. Only by exchanging information, only by getting the necessary data, by doing the test, will we ultimately find the right solution to hopefully terminate this disease, end of this year, next year, or third year, whatever it is. So I hope that answers your question, is that we are promoting the antibody, because the nations that need it needs rapid result, not in 3-5 days a week. They need result immediately, because they're trying to counter the issues at the border, and you cannot hold millions of people at the border indefinitely. It's just not practical. And at least of the diseases, we have to be practical. We have to be socially, and that's why, yeah, I brought up the comparison with the flu and car accident. But in a year, 2 years, we'll have to treat this just like that. Is this like car accident? Is this like flu? What do we do? Do we continue this panic for 3 years and collapse the entire world? I mean, is that reality? Or do we treat it like, oh, it's just a car accident? Yeah, a lot of people are going to die, but a lot of people die in car accident. So we have to, as a society, as a world, we have to determine that. And that's only going to come through information, through experts like you have brought on this panel to tell the world the truth, the fact, and to analyze it. And I am blessed to be among such panels of experts that you have brought. Thank you very much.
And again, Dr. Ying, there is another question I just saw here on the window.
I have a quick
from
question
Sachin Gurung, Dr. Sachin Gurung. Is there a particular window when the test is most accurate?
Again, there's obviously various tests that, like in the antibody, for example, there are various determining on which supply. Again, I'm not going to go into detail because I'm not here marketing who's
right.
Yeah. I'm not a commercial platform. But some will say, well, this can do a positive test, give you a positive result within the first 3 to 5 day window of infection. And others will say, well, this test will be 5 to 8 days. But a lot of that is not just determined on the sensitivity. but it's also determined, like example, how much of the viral particle are you swiping. It is a complex issues that's determined. How much are you actually determined? How many days activity? But in the antibody, typically to get enough antibodies in the body, the typical data suggests that you need at least 3, 5, or even as many as 8 days before you can get a reliable test. But that's determined by the test itself, by who's applying the test. So there's a lot of parameters. But again, a lot of this is we're just finding out. These tests are only been involved a few weeks. So a lot of this is the expert, like these on the panel. These are the experts that needs to tell us, that say, well, this is how you test it, this is how you swipe it, this is etc. And this is the result that you need to wait. You need to wait at least 3 days for a positive result. Those are all data that need to be fully analyzed and assessed. So I cannot give you a concrete result, but based on the analysis of various tests that I've seen, it is very variable. And a lot of that variability is we just don't know. It's a simple answer.
Somnathji, can I supplement a little bit here?
Yes.
So for the current knowledge and practice, we do the real-time PCR to check disease on the day 1. So antibody test at least takes 5 to 7 days to detect the virus, because the antibody takes time to develop in our body. So if you have developed that test for IgM, it will be 5 or 7 days. So if you have developed to check both IgG and IgM, then it might take 15 days to get that detected. So I do not know what kind of test you have been trying to develop, but for now, real-time PCR is the best until the virus is active. From the research, WHO and CDC has said that if you have a disease, and even though you have a virus, your virus could be present up to like 6 weeks or 7 weeks. And I have seen my patients, they have been positive for 6, 7, 8 weeks up to. But from the knowledge so far we have is after 10 days, the virus is in your body. The replicability or transmissibility of that virus is 0 at 10th day in one patient. So if your test is antibody test, that will give you result immediately. If you have IgG or IgM or both or whatever, what kind of test you're going to develop. But from the current knowledge, your test will be positive. That antibody test will be positive up to 6 weeks, and that may mislead the guideline for the treatment. So I do not know what your test is going to be, but all the best for your test, and text kit will come and it will be better. But just my 2 points on this.
No, you speak absolutely. I totally agree with you. Absolutely 100%. Of what you commented. The PCR real time is the absolute ideal test. But the reality is we don't live in an ideal world in Africa or certain part of Asia or whatever, you know, maybe an ideal world in America or Europe where they can afford such PCR, they have the expertise, etc., which these PCR live tests has only been developed recently. So it's not like, oh, we just developed this for COVID-19, it's been stockpiled. So that's the reality. So yes, PCR live is the ideal perfect test to do. So I don't want to give people the misconception that I'll just do an antibody test, that's all. No, absolutely not. But when we consulted with these African nations, we gave them more. We said, listen, you need a PCR test, which is the most accurate and can basically give you data that the person has been infected right now. The antibody, like I said, based on that, you may need the patient to be infected for 3-5 days, depending on swipe, blah, blah, blah. But the reality is the cost, the reality is the time. These people are being tested at the border. So you have to factor in the real time experience of that particular nation. They may not have a lab test sitting by the border custom with the, you know, with the border guard, etc. So you have to put together the best case scenario that can at least give them some data that they can make some sort of concrete policy. Is it ideal? Absolutely not. but it's better than nothing. And that's what we're trying to give them. We're giving them something that's better than nothing, so they at least have something to work with. But you're absolutely right, sir. What you said is 100%, and I will not go against what you said. It is 100% precise. But we live in a reality, and the reality is not based in America. The reality is not based in UK, the reality is based on the front line of nations that cannot afford what other nations can afford. And we have to work to what they can afford, what is practical on their basis. But I totally agree with you. You are 100% right, totally. Thank you.
Thank you, Dr. Leong. This is the last question of the forum today. For Dr. Lochan Karki, President of Nepal Medical Association. Please don't mention my name. Somebody just wrote it. Okay, we'll keep that secret. Right now, Nepal is increasing in the number of COVID-19 cases. And country itself, the government of Nepal itself is not well prepared to combat this COVID-19. We are not confident to fly back or to go back to Nepal because of this epidemic, of these outbreaks that might come in increasing number in the days ahead. So what do you suggest to all Nepalese around the world to whether they go back to the country to increase the number of outbreaks until and unless government is well prepared?
Well, thanks for the question, but the question is a very tricky one, and it's very difficult to answer, because firstly, I would like to say that the choice is yours. The thing is, it's your rights. If you want to come back, you come back to your country. It's your rights, and the government should allow you to come back to your country, and it's responsibility of the country, being it's a responsibility to bring the countrymen to their home back and do enough preparation. And I really agree that for this, the government has to be prepared. They have to be prepared for the good quarantine, for the test, and if necessary, for the treatment as well. Without preparing for the enough test, good facility quarantines, and preparedness for the treatment if necessary, it would be disaster to bring a lot of people in country without a preparedness. So I think it is duty of the government to be prepared and to bring all the Nepalese who are interested to come back home. So number one, I believe to come back is the rights, and to bring back is the duty, and to prepare well is duty as well. So I think that will be my answer.
Do you think, yes, do you think they're gonna, you mentioned that quarantine is not a good way to stop this virus. So if the people from all over the world come in, and it's a huge number of people.
As I again said, the quarantine should be of WHO standard. If the quarantine is not of WHO standard, it can be a source of infection. The researches, the papers has been published, which have clearly told if the quarantine is of not, if it is not of WHO standard, it can be a disaster. So firstly, the quarantine of WHO standard has to be maintained. And there are a lot of different, look, the lot of countries have practiced different kind of quarantines. It could be hotels can be used because they have separate rooms, separate bathrooms, and we can use it as a paid quarantine if people are interested to live in, or government should be prepare. I mean, like they have to prepare for a free quarantine. But if the quarantine is, and even home, first of all, we need to understand about self-quarantine. We need to understand about quarantine and isolation, the definition between those two things. And even if somebody can stay knowing the definitions and the guidelines of self quarantine, even they can stay at home. But the most important thing, the country should be able to look whether they are maintaining the rules and guidelines of self quarantine or not. If the other thing, the preparedness of the quarantine, that's very important. If the people are not kept in a proper quarantine, if they are not done test, then they again can be the source of infection. So that's very important.
Thank you. And we have the last sayings. Just got the message from Dr. Kevin Moore.
Yeah, I just wanted to say about, I think following on from that, so I think people were asking about traveling home and things like that. I think it's important that if you live with family who are at risk, you do not put them in danger. Currently at the hospitals, if we are living with kind of people who are high risk, they're actually paying for hotels and things. So we're not kind of like putting our family members at risk. So it's important that we don't put people at risk by just going home. I haven't seen my mum for about 5 months physically, but we use like kind of technology to kind of get past that. And also just one last thing, about PPE, when we use it in hospitals, it's single use. I see people use it on the tubes and then they start touching personal items like lipsticks and then start touching things like phones and things like that. It doesn't really work. You shouldn't really be touching things like multiple, because you're kind of passing it on to things. You're not really like protecting anything. So it's important that when we have PPE, we're using it properly. Like just look at the guidances that you get with the equipment and things like that. So yeah, just have it, but use it properly. That's my advice.
Yeah, and I'd like to add one thing. Even I mean, like Sachin is here. I mean, like even in UK, even infected people live in home. I mean, like if they maintain the guidelines, they can even stay at home. So they aren't admitted in a hospital until and unless they are very severe. And even there are practices like Singapore. There was no lockdown. There was separate quarantine. They just picked up the infected cases or positive cases and kept them in quarantine. But the things were going on in normal. So it's just about breaking the chain of transmission. So for that, you need to have your own guidelines. There are different formulas for the different countries. I mean, like different countries are practicing in a different way. So we need to choose the organic one, because we can't copy the formula of any other country, but we need to see our own setup, own our I mean, like social values, economic values, and we need to make our own organic way of not transmitting disease to other and breaking the chain. That's it.
Okay,
Yeah.
Dr. Sachin Gurung, go short.
Yeah, I mean, like, yes, Dr. Karki, in an ideal world, everything would be WHO standard and we would have quarantine all over the world. But then again, like I still have my parents back in Nepal and also have very close relatives back there. Yeah, I haven't seen them for a very long time, but God forbid, if there is a family emergency, there is no provision of me going back to Nepal. There are no flights that are flying to Nepal. And there are so many people from who live in India and the neighboring countries who have now lost their jobs because of the pandemic and I want to come back to Nepal and they're all stuck in the border. So I think, there should be a provision. Yes, ideally, we would want a strict quarantine and then we don't want to spread the virus. But yeah, if there is a family emergency or like a real emergency to go and visit your family members, I think there should be a provision for those people like me.
Yeah, and I'd like to add about Nepal. I think I should be very honest, because the quarantine in Nepal is very difficult. You know why people are like running out of the quarantine? They are like jumping out of the quarantine because the quarantine is something like a jail. The food provided to the people there and the way they are kept in is really difficult. Even if I'm positive, I'm afraid of going to the quarantine or even to the hospital, because the way it's been, I mean, like the people they're kept in is really difficult. And I think we need to, we are pushing the government to look into it very seriously. Otherwise people would hide their disease. They would rather stay at home rather than going for like quarantine or something like that.
All right, so thank you so much, all our health heroes who took your precious time And we salute you for your leadership in combating this COVID-19, the deadliest virus, for your courage, for your dedication, for taking care of our patients. We salute you again. Thank you so much for your valuable knowledge, for your advices, for your views, for your opinions, and we gain a lot of knowledge. I hope all our viewers could learn a lot of things from global doctors' leadership in the time of COVID-19 crisis forum that we just had. And thank you again. I would like to conclude this meeting from our Honorable Sujata, Chairperson of GPK Foundation.
Thank you.
And Deputy
Thank
Prime
you, Somnathji, for organizing this wonderful program. Lot of things I learned from this. Lot of things. I'm going to advise and speak in Parliament. Few advice I have noted it down. Is very useful for Nepal. Thank you so much. Thanks to all the doctors, everybody who participated and gave us knowledge. Thank you so much. Namaste.
Thank you, everyone. Take care. Bye-bye. Good night. Good evening. Thanks.
Okay, bye.